really quick overview of all the retinal issues that we need to be on the watch out for. Now, our next talk will be by Dr. Lathika, who will talk to us on the leads from the pupil and the optic nerve. So, Dr. Lathika, over to you.
Okay, so I'll be talking about what the optic disc hides and what the optic disc can tell us in cases of suspected functional vision loss. And the scope of this talk will be mainly focusing on the missed, the mistaken, and the mysterious that we come across in the optic nerve pathway. So these cases are often baffling and sometimes referred also. So it's very important not to hurry and not to delegate, because there is no room for error and you're making the patient do many of these tests over and over again. So I'll start right from the history. Just one point in history taking is that your prompters should be very precise, because many of the symptoms in optic nerve disease are quite vague. So unless you have, I'm just putting some examples there only. So unless you ask about each of these specifically, especially even the field defects, they may not come out with these helpful hints. And if a patient talks to you about transient visual loss, then the two important things that you can ask to localize the pathology to the optic disc may be a short duration of the attack. That means less than 15 seconds or so. Then the pathology could be in the disc, and also the precipitating or relieving factors that we are all familiar about in optic neuritis. But you need to ask that, otherwise the patient will not tell you. And any patient with an unexplained visual loss, we are in a hurry to dilate, see the fundus, and look at what is happening there. So it's better to have a checklist in the OPD before you do that, because you cannot come back and do these things reliably. So it is always good to have a checklist with all of these things and make sure that it has been ticked off before you call for dilatation. Now, regarding, these are just points I'm picking from our daily OPDs. So regarding color vision, Ishihara is what still we all do in our OPs, but it's a very gross test of color vision. So it is not, especially in the early phase of an optic neuritis, it is just not enough that the patient recognizes colors, but the speed of recognition of colors is also important. Only an experienced refractionist can pick that up. So it's better that you go and do it yourself and see what is happening. So another thing, a very simple thing you can do is the red cap test, where you can show these bottles with red caps in front of the patient's eye simultaneously and ask the patient whether there's a washout or not. So they will very quickly pick it up themselves. Now, pupil, of course, is a vital clue. I don't know whether this video will be very, very basic. I have a video on that. Can we? Yes. What's happening?
To check the pupillary reaction, dim the room lights. Ask the patient to look into the distance to relax the accommodation. Make sure that you have a bright flashlight. First of all, assess the size of the pupil and make sure there is no anisocoria either in bright light or in dim light. Next, assess the direct light reflex by shining a bright light into the pupillary area and looking for the briskness of the pupillary reaction in the same eye. Next, for the consensual, you have to throw a bright light into one eye and see for the pupillary reaction in the other eye. You can place a barrier or a hand so that there is no spillover of light from one eye to the next. Also, to aid in better visualization of the pupil, you can use a reflected light in the eye in which the consensual is assessed. So the consensual is seen very clearly by using a reflected light. Next, you should assess the near reflex or accommodation and pupillary constriction during accommodation. Now let's move on to the swinging flashlight test. This is a patient with RAPD in the right eye. So you shine the torch into the normal eye. You can see the pupil constricting briskly. Now swing the light over to the affected eye. You are expecting the pupil to constrict, but here you can see that the pupil is actually stalling and trying to dilate. This process is repeated once or
Okay, so just the things to highlight are: don't go and stand in front of the patient, let the accommodation relax, and also the light should be dim, but your light should be very bright. And assess each pupil separately before you go on to the rest of the pupil assessments. And nowadays, I personally use a magnifying loupe to assess the pupil. So that is, I think, very helpful for me. So quantification of RAPD, yes, it is important, but it is not as important as detection. So once you detect, your diagnosis is okay. So quantification, of course, you have a grading, but neutral density filters, pupillography, everything is the objective grading. So now we come to certain clinical questions regarding RAPD and its significance. So in patients with defective vision, there is no RAPD. That equate with a healthy optic nerve. Not always. If it is bilateral defective vision, if you're dealing with a bilateral optic neuritis or any of the symmetric optic neuropathies, especially a Leber's, then you may not be, actually RAPD may not be detectable in those cases. Also, if your pupil is already compromised due to a third nerve palsy or a trauma or previous surgery, again you cannot assess an RAPD reliably in such patients. So in bilateral defective vision, what is it that you actually assess? It is the pupil cycle time, which may help you. It is
cycle time is about 954 milliseconds
throwing
or
a
better.
horizontal,
So here
it's
we
called the
go.
pupil cycle
I'm gonna
edge
take
time,
my
because
half
the
millimeter
horizontal
pipette,
light
put it
is
right
thrown
on the
from
edge of his
to the
pupil, and watch.
100 time required for 100 cycles of constriction and dilatation is known as constriction and dilatation. So it is generally around 840 milliseconds considered normal. Anything above 954 is considered. So that is one thing you can do in a bilateral
Cycle time.
of the pupil. Now I'm going further into the eye, and let's go to the difficult disc, where a green filter evaluation I found very useful in all optic disc assessments. So let's see this clinical scenario where there is an acute onset gross defective vision in one eye, and you see an RAPD. You are expecting the disc to be abnormal, but it is abnormal. RBN I'm not going to talk in detail, because we all think RBN first in this scenario, but I'm going to focus on the significant other, which means first is PION. PION, that's posterior ischemic optic neuropathy. All I want to highlight here is that generally we come across, when we say PION, we think of the arthritic type of PION. After surgery or after trauma, generally after trauma in the ICUs, we see gross defective vision due to a probable PION. But here I'm talking about a PION which is non-arthritic, and the patient can very well walk into your OP with a moderate defective vision and an RAPD and a normal disc. So don't always say think it is RBN. There are some other things also you should be looking at, like for example, this will maybe one word more about PION versus RBN. See, in PION, the visual loss is usually central. And also when you take the VEP, because it's ischemic, it is the amplitude that is down compared to optic neuritis, where it is the VEP latency that is more affected. So and the changes prognosis wise, it is permanent and irreversible in PION. Okay, so and why should we be aware of this? It's not only for the diagnosis, but the workup and the prognosis is very different. In an optic neuritis, we may have an autoimmune type of battery of investigations, whereas in the other, it is usually a vasculitis we have to exclude, and a complete cardiology evaluation is a must. And prognosis also is very different. So this we'll skip. So an RAPD and a normal disc, what else? It can be any of these in the early stages. All I want to say is it can be a lot of optic neuropathies in the early stages which look rather normal. Only in the late stages they go in for a slightly swollen disc, and then later on to the pale disc. So just because if you find an RAPD and a normal looking disc, at least it is not always an RBN. So that's a take home I was just looking at. And second question is very often we come across temporal pallor. Temporal pallor just means selective affection of the papillomacular bundle. So is it an ongoing disease? Is it old ischemia? It's for us to distinguish between which is which. So this is a scenario where a 54-year-old man comes to us with a chronic progressive defective vision, 618 OU and a slight cataract. There is no RAPD, but the disc is showing a mild, it is showing a temporal pallor. So our confusion was whether to go ahead with a neurophthal evaluation or do a cataract surgery. So again we looked at the so that's when we perused the records and then found that he was a tobacco alcohol addict, and then we started thinking about this toxic or possibility of a toxic optic neuropathy. The fields came up with a centrocecal, but before labeling the point is even if there is a centrocecal, before labeling it as a toxic or a nutritional optic neuropathy, even in this patient, it's very important to rule out a compressive optic neuropathy. That is why we have to send for a neuromedicine consultation, and MRI was done, and then the cataract surgery was deferred, and it was a vitamin supplement that was advised by the neurologist. So the point is you have to be very, very diligent in scrutiny of records. In some cases, these are the symptoms that may help you decide whether this patient needs a neuroreferral or not. Now coming to the investigations that can help you, we all rely on perimetry. Most of the time a 30-2 is fine. Just remember that the metabolic causes usually have and the demyelinating ones usually have a central and centrocecal. If you find an altitudinal defect, it's more likely to be an ischemic cause, and if you find hemianopias, it is usually, you have to think high suspicion for compressive lesions or masses behind the optic nerve. Now, VP, as I just mentioned, it is not mandatory in the diagnosis of optic neuropathy. It's useful, but in patients with subclinical findings and medial opacities in infants and such, only in selected cases. And as I said, increased latency, always it is a demyelination that is more likely, and if it's a reduced amplitude of the P100, it is more likely an ischemic episode. Now, neuroimaging is a must. You should not think twice about it if you really feel it is indicated. MRI orbit should be for if you have a suspicion of, that's how we customize. If you really suspect a compressive optic neuropathy, then you go for MRI orbit. If you have a bilateral field defect or atypical optic neuritis, it is MRI brain is a must. In vascular pathologies, angiographs, MR angiography, and now we have we have to categorize demyelinating optic neuritis or immune mediated. A lot of findings are there in the MRI. So anyway, it is an indication. And always communicate with the radiologist for better results. OCT is now coming up in a big way in the follow-up, especially of papilledema and optic neuropathies. You have to, RNFL, the programs are RNFL and ganglion cell analysis. These are the two things we have to look at in following up these patients. Blood, of course, you have to have a CBC. Look at ESR in particular, because a lot of things can lead to inflammatory, infective, all sort of things can be there behind an optic nerve inflammation. Also, the nutritional optic neuropathy needs serum B12 and RBC folate. Technically, we actually don't do it. We go for a clinical examination and antibodies, as I said, to categorize optic neuritis. Never shy away from consultations. It is always a teamwork. Neurologists, psychiatrists, immunologists, hematologists, internal medicine, the entire battery and the team has to be called in as and when necessary. So in conclusion, the take-homes are to aid your neurophthalmic diagnosis in cases of suspected functional visual loss. Make sure that you have a precise prompters for a productive history. You have a checklist before dilatation. Your pupillary examination is scientific and technically right. Your interpretation of RAPD should be cautious, and in relation to the fields in the disc, you should be diligent and prompt in your investigation, appropriate cross consultations whenever necessary, and always keep an open mind for atypical and early presentations. Thank you very much.
Thank you, Dr. Lathika, for that wonderful talk. Just a couple of points. This is the most difficult part is when you have a person coming to your OPD with maybe 6'9", says there's some blurring, the disc looks slightly pale,
Yes.
and you do your OCT and there is maybe 1/4 RNFL thinning, and now you don't know what to do. So because if you advise an MRI and comes out normal, you have an explanation to give. So, what would you do next?
Yeah, that is when, as I said, that is what happens, a temporal pallor or a slight pallor. I don't do an OCT first for those patients. I go back and, review that patient's history and case sheets thoroughly. Generally, some drug somewhere, even the tobacco alcohol is so common, and some drugs somewhere. So that is when I do a new, if I can get a clue, I send the patient over to that consultant to stop the drug or whatever, modify the drug or look at it that way. And I send for fields next to see
Fields
what is
perhaps the most important too, because many of these bilateral visual field, they will not cause any pupil issue, so you will not get any RAPD, and fields will give you a definite clue. And there, if you have something obeying the vertical midline, it need not be a hemianopia, it need not be a proper quadrant, but if it is obeying the vertical midline, immediately think that you're justified in imaging.
Yeah, fields will also tell you whether you're looking at a compressive cause or whether you're looking at a metabolic or toxic cause. That's what I do. I send for a fields and then. Yes, PION. Frankly, I have come across PIONs in the ICUs mostly. I have come across 2 or 3, or maybe not many, but in PIONs in the ICUs. So only then, after some time, I've got the patient in the OP to actually see. By the time they were all in optic atrophy, and I could not actually see the face practically, but theoretically PION is ischemic, so they have very steep cut borders and central is affected, whereas optic neuritis, the whole battery of field defects are possible. So
MRI can help in the acute phase. If you do an MRI and you ask the radiologist to look for diffusion restriction in the posterior part of the optic nerve will be there in PION, but it's there only in the acute phase. Later it will not be there.
But
that is one way to distinguish.
And you can do fields in the non-arthritic type. This is how they have that is from the literature I am saying. In the non-arthritic type, and the patient is walking into your OP, you can look at fields and have a clue, because it is central, it is ischemic. Basically the field is ischemic.
Thank you.